And it is my great pleasure to be with all of you today talking about post-traumatic epilepsy. So I'll try to be as simple as possible, but not simplistic. So I hope that at the end of the webinar, there will be the opportunity to go through some of the points that may be not completely clear, but I'm trying to do my best in order to make everything as simple as possible. This is my disclosure. So first of all, what is a seizure? What happens in the brain of someone who has a seizure? And what's the difference between having a seizure and having epilepsy? Many of you may have an idea of what a seizure is because they know someone who has epilepsy, or they may have seen it. But what happens in the brain? The brain is like the computer of the body, the electric system of the body. As you know, everything runs through electrical signals. And an epileptic seizure is simply an electrical shortcut happening in the brain, in one area of the brain or involving the whole brain. Having an isolated seizure is not that uncommon. It is estimated that up to 5% of the population can have a seizure during their life, sometimes for reasons not entirely clear. Epilepsy is different, and in that regard, the International League Against Epilepsy, that is the World Scientific Association for Epilepsy, published a new practical definition in 2014 in order to make that easily understandable to all clinicians. Epilepsy is the enduring predisposition of the brain in having repeated seizures. So the electric system of our body has some sort of predisposition in having these electrical problems, and this predisposition has been quantified as a risk higher than 60% in having a seizure, a second seizure after the first one in the subsequent 2 years. This 60% is on a balance high enough to recommend taking anti-seizure medications. So based on this, 1 in 26 people in the world have epilepsy, 50 million people worldwide. So something not uncommon at all. In traumatic brain injury, the situation is more complex because obviously seizures may represent the symptom of the underlying brain insult. This is what happens at the very beginning. Shortly after a head injury, people may have a seizure. And these seizures are called early seizures or also acute symptomatic seizures. They are a symptom of the brain insult, and they do not represent per se the onset of the epilepsy. There are then other seizures happening later on. They are called late seizures, and they unfortunately are the consequence of a number of chemical changes, structural changes in the brain that lead to this enduring predisposition. The scar in the brain or other reorganization of all the wires, the networks that unfortunately account for this enduring predisposition. And this is post-traumatic epilepsy. Now, at the moment, based on epidemiological studies, so based on numbers of many patients affected by seizures after head injury, at the moment, everyone is identifying as 7 days as the cutoff to distinguish between early seizures and late seizures. This is something that is under discussion at the moment, may change in the future, but this is what is usually used by all doctors. Now, as I said, early seizures are not associated with an increased risk of having subsequent seizures, so they do not represent post-traumatic epilepsy. But when they happen, it means that the head injury is pretty serious, that the patient is pretty sick. So this is why they are sometimes treated. Having an early seizure is associated with an increased risk of dying because of the severity of the head injury in the subsequent 30 days. This is why sometimes doctors decide to start the patient on anti-seizure medications, even that early, in order to try to minimize the risk of dying or other consequences because of having these seizures. Obviously, it is also very good practice to explain that these medications should be gradually weaned and stopped when the patient is more stable. Also because if you carry on taking the medication, any late seizure, that is the onset of the epilepsy in itself, are also controlled by the anti-seizure medication. So it is impossible to understand if someone has developed post-traumatic epilepsy or not, if someone takes anti-seizure medications for months or years. The problem of post-traumatic epilepsy is that unfortunately seizures can start anytime. There are some anecdotal observations of patients that have developed after a decade or two. This is obviously due to many reasons. The rewiring may still be very efficient when we are young, but then when we age, that rewiring that happened many years ago may not be as efficient anymore. And this is why people can develop epilepsy after a long time from a head injury. Again, post-traumatic epilepsy is a symptom of the severity of the head injury. It happens very rarely, very occasionally in a mild head injury. It happens definitely more frequently in someone who had a very severe head injury with a skull fracture, with a lesion in the brain. So the first question I'm sure everyone has, so is that possible to prevent the development of post-traumatic epilepsy, giving some medications almost immediately when someone had a brain injury? At the moment, no. In the last 30 to 35 years, researchers have tried a number of drugs, many compounds in many different studies, and none of them unfortunately managed to stop the kind of changes happening subsequently leading to post-traumatic epilepsy. Definitely anti-seizure medications don't prevent, because they simply help the electricity running smoothly through the brain, preventing seizures, but they do nothing for the chemical changes happening in the brain. They are not neuroprotective agents. They don't protect the brain when it is under stress. Now, having a head injury obviously means a lot in terms of brain performance. I think all of you is very aware. The development of post-traumatic epilepsy represents what all of us call a sort of second hit, because obviously the brain now has to find a new balance, a new baseline to function normally with this electrical problem. Obviously, controlling seizures completely is the best way to then find quickly a balance. Otherwise, obviously, the brain will find ultimately a new balance. But this is why all patients perceive that their, for example, cognitive functioning is not as before. They said, I was just stable, or I found a sort of balance after my head injury, and now, since I had my seizure, my memory is again not as good as before, or other changes in the sleep or whatever. Unfortunately, this is what happens. And the best thing to do is obviously to take medications regularly, to try to control seizures as much as possible in order to support the brain in finding a new balance, a new baseline as soon as possible. Why all of us treat epilepsy? The main reason is SUDEP. SUDEP means sudden unexpected death in epilepsy. This is not a disease, this is not a condition, this is a category of an uncommon sudden death, meaning a person otherwise healthy dying unexpectedly. This is the main reason why all epilepsy specialists, all people working for patients with epilepsy, always explain why it is important to treat seizures. Obviously, SUDEP is not frequent. It is infrequent. 1 out of 1,000 people with epilepsy dies of SUDEP each year. That is still a lot, but as I always say, is obviously much likely to die in a car accident rather than SUDEP. But this is still very relevant if you have epilepsy. The reasons, probably there is not a single cause. What we know from research is that the electrical disruption involves key areas, unfortunately, in breathing control that can happen during a seizure or shortly after. I have put in my slide also the SUDEP Action Association website. It is the Association of Patients providing supported information about SUDEP in general. So the usual question is, so could SUDEP happen to me? What we know from statistics is that the most relevant thing is to have grand mal seizures, the big seizures, the convulsions, the seizure that everyone has in mind in sleep. Being a young man with a very early onset of the epilepsy during infancy are obviously risk factors. Not taking medications, because in this way seizures obviously are free to happen. Using alcohol and recreational drugs are very relevant risk factors. So everyone can lower the risk, taking medications regularly, get enough sleep for sure, avoid alcohol and recreational drugs, recognize seizures in sleep, and work with your doctor in order to achieve better seizure control. Try new medications, make changes, and make sure that if you have to start a new plan, you can start that as soon as possible and keep a pace. Then the usual question is that there are monitor devices in the market. Are they relevant? They are relevant if there is someone able to help performing CPR, or room sharing is still the most relevant prevention factor for SUDEP. So how do we treat post-traumatic epilepsy? We have a number of drugs. Anti-seizure medications represent the first-line treatment. Epilepsy surgery, that is still a valuable option in people with post-traumatic epilepsy, and neurostimulation, definitely vagus nerve stimulation. Ketogenic diet is also an option, less used in adults, but is still available. Then there are a number of new drugs and new compounds under investigations out there in the world, including, for example, even stem cell transplants, that is quite futuristic. Drugs, as you can see from this graph, in the last 100 years, many different compounds. We have almost 30 different drugs. Unfortunately, even today, it is not possible to predict which drug is the best for the individual patient. But what we know is, again, that around 30% of patients become completely seizure-free and controlled on the very first drug that they try. Then there is another 30% that become seizure-free, trying a second option or a combination of two drugs. Then, unfortunately, there is a remaining 40% of patients that have tried multiple drugs and none of them seem to work for them. This is called drug-resistant epilepsy. This is obviously not just for post-traumatic epilepsy. This is in general for all people with epilepsy in general. So still the approach is through trial and error steps. So if your doctor recommends different drugs, this is because this is how practice is at the moment. All of us aim to try to control seizures in the best possible way with the minimum side effects. But unfortunately, drugs have side effects. And you have to guide us in identifying what drug is the best for you, okay? Then, as I said, especially for people that are drug resistant, for that group of people that don't respond, we have non-pharmacological approaches. Epilepsy surgery. Epilepsy surgery is a very established treatment for a number of conditions. It means to remove an area of the brain that has been identified as the only one responsible for the electrical shortcut. In many cases, people with head injuries are not considered immediately for epilepsy surgery because there is the idea of multiple areas or the scarring can be complicated. That's true, but it is always worth at least understanding and considering whether this can be an option for you. So feel free to discuss with your doctor, and obviously epilepsy surgery is usually performed in tertiary or quaternary centers, very specialized in this treatment. But also NICE considers head injury as one of the potential cases for epilepsy surgery. Neuromodulation is a very valid option. In the UK, only vagus nerve stimulation is commissioned, is available in the NHS. There are a number of other neurostimulation techniques available in Europe, but not in the UK. But still, VNS is a very valuable option. It implies a pacemaker connected to the vagus nerve, that is a nerve running in the neck. And apparently the stimulation of this nerve is resettling the electrical activity of the brain. And this is why it has been used for a long time as a non-pharmacological treatment for seizures. The operation is very small, and I think it can be performed in many centers. It is an option that it is important to consider for people that have drug-resistant epilepsy. Then, unfortunately, having epilepsy doesn't mean just having seizures. 50% of adults with epilepsy have at least another medical condition. This happens much more frequently than in the general population. And these additional medical conditions that we call comorbidities represent, usually account for the medical cost of having epilepsy, but also for the disability associated with epilepsy. So in this way, epilepsy and head injury shared a very common path, because also head injury is associated with a variety of different problems, and not just head injury in itself. So you understand how people with post-traumatic epilepsy have to face a variety of different problems at the same time, not just having the seizures, but all the psychological consequences, anxiety, depression, post-traumatic stress disorder, neurological symptoms, cognitive problems, sleep problems. This is why it is important to have a multidisciplinary approach to all people with epilepsy in general, but even more for people with post-traumatic epilepsy. There is a lot that we can do. There is a lot that patient associations can do. First of all, education, inform patients, empower everyone in order to know and to be aware what can happen, because obviously for us can be challenging sometimes in a short period of time to identify what the needs are for the individual patient. And sometimes is only through the journey that we understand what is relevant for that specific person. So being already aware of what can happen to identify quickly what the needs are. Then for services and for patients' association to establish partnerships and links with a number of other specialist services, for example, mental health, psychology, and advocate access to these services for people with epilepsy that unfortunately, even today in 2025, are stigmatized compared to other medical conditions. Then for neurologists, obviously, it is important to identify all these problems, to be aware of all of them, to be aware of all the drug interactions, because people with multiple medical problems at the same time may need to take multiple drugs. But the ILE, the International League Against Epilepsy, is very active in providing all specialist guide and support with a number of very relevant documents. So to conclude, unfortunately, even today, post-traumatic epilepsy is common. It represents 1 in 5 of all symptomatic epilepsies and 1 in 20 of all epilepsies. The good news is that more than half of patients can be completely seizure-free on anti-seizure medications. It is important to take the medications regularly in order to achieve that. And for those that don't respond, there are alternative options available to try. People with post-traumatic epilepsy have multiple needs that require multidisciplinary approach, and it is important to all of us come together to support research in this direction. So I'm now happy to hand over to my colleague.
Thank you very much, Marco, and hello, everybody. My name is Laura Price, and I'm the Research Programme Manager at the Epilepsy Research Institute. And I'd just like to spend the last sort of few minutes of this webinar talking about the Institute and our mission to radically advance research into epilepsy and how we involve people with epilepsy in our sort of day-to-day function in our business. So we were originally Epilepsy Research UK, and with support from some of the other epilepsy charities in 2023, we asked the government to grant us institute status, as we knew this would really set in motion our mission to drive epilepsy research in the UK. And we were granted institute status, and so the Epilepsy Research Institute was born in October 2023. Okay, if I can have the next slide, please, Marco. Okay, so as you can see here, epilepsy, and you will have picked up from Marco's talk as well, there are a lot of unknowns about epilepsy. It's a hugely complex area. And what I've done here is simply list some of the conditions that can give rise to epilepsy. And as you can see, it's a huge list. It's a vastly complex area. Post-traumatic epilepsy I've highlighted here, but as you can see, there are structural, metabolic, infectious, immune and genetic causes. And when we're thinking about the genetic causes of epilepsy, for example, there are more than 900 genes now that have been linked to epilepsy. They don't all cause epilepsy, but they change in some way in people with epilepsy, and we need to find out why. So studying epilepsy is complex. It presents some difficult challenges, and we sort of started our work looking at this huge array of questions, wondering where to go. So the initial piece of work that we did was if I can have the next slide, please, Marco, is we did a piece of work called a priority setting. And we did this in association with the James Lind Alliance, who carry out this work with a whole wide spectrum of charities, and they're really well practiced in this process. And it starts very simply with asking people who live with epilepsy, the health professionals who care for people with epilepsy, and the researchers working in the field of epilepsy to say, well, you know, what do you think are the most important unanswered questions at the moment? And you get hundreds of responses naturally, but then there's a series of steps where people sort of take out all the ones that overlap and narrow them down and keep involving the people who were originally giving those questions. And eventually we can refine all those questions into a top 10 list of priorities. And you can see here our top 10 list of priorities. And these priorities have really shaped the way that the Institute has started looking at where to really focus our attention on initially for research. And you'll probably see that quite a lot of these are very relevant to people with post-traumatic epilepsy. So we took those top 10 priorities and we used those to shape our research programme. So we identified that probably we could fit those 10 priorities into 4 main areas of research. So that's neurodevelopment. So how does having seizures affect how the brain develops? And how does how the brain develop affect your likelihood of having seizures? We've got advanced therapeutics and disease modification. So you'll recognize that Marco said that anti-seizure medications, they suppress seizures. They don't actually cure epilepsy. So are there ways now with some of the new treatments that are developing that we could actually go in and actually change the course of the disease so that actually, you know, you are cured of epilepsy? Or are there perhaps medications that are being used for other conditions? You know, there might be completely different conditions that might actually help people with epilepsy as well, but they haven't been tried. We've got mortality, morbidity and risk, and immortality, morbidity and risk, which is really hard for me to say. We look at SUDEP, we look at the risk of some of those comorbidities that Marco talked about. We're about to start some work looking at mental health in people with epilepsy. And reproduction and hormones, hugely important area. A lot of the anti-seizure medications can't be used in pregnancy, or they have to be very carefully managed in pregnancy. But there's also a huge number of unanswered questions about the roles of hormones for people with epilepsy. How do they affect people's seizures? So those are our 4 key areas. And then to complement those, we've got 2 sort of cross-cutting themes, which are enabling technologies. So that area is looking at sort of what are the technologies that help people do the research, you know, the AI, the sort of huge new imaging machines that are coming into use, but also what are the technologies that can help people with epilepsy in their day-to-day lives. And the final sort of area that we focus our research program on is capacity building. It's really important that we really build and support the epilepsy research community. I mean, they do all the work for us. They are, you know, they are the stars in on our horizon. And so our capacity building theme is looking at ways to support researchers, bring in early career researchers, enthuse researchers about working in epilepsy, and making life easy for our researchers as well. So for each of our themes, we're very lucky to have 3 who we call theme leads, who are academics, people researching, and clinical research as well. So basic science research in the laboratory, but also clinical researchers who are out working with patients. So we have a 3rd theme lead who is an early career researcher. As I said, it's really important for us to support early career researchers, and one of the ways we do that is we offer this opportunity to come in and work with us as a theme lead. And the theme leads for each of our research theme are supported by a task force of expert researchers and clinicians from international and UK, and Marco, for example, is a highly valued member of our task force for our mortality, morbidity and risk theme. And you'll also see on the graphic some SHAPE members. So I'll talk in a minute about the SHAPE network. but they are people with lived experience who we bring into our advisory group as well. I just realised I'm running out of time, so I'll skate through some slides, I think. Right, so yes, the next slide is about our SHAPE network. So we're privileged to have our SHAPE network of people affected by epilepsy who are interested in research. We've got 716 people at the moment signed up to our SHAPE network, and through their membership of the network, they can become involved directly in research. So we use these people, for example, we fund research directly, and when we shortlist applications for funding, we invite the researchers to speak to members of our SHAPE network. Our SHAPE network can ask questions about the research. They can discuss the research directly with the researchers, and then they can come away afterwards and they can tell us how important they feel that research is for funding. And so we run a side-by-side process with experts doing the same thing, and that so when we come to make decisions about where to place our funding, we've got both sets of opinions. And we also share opportunities to become involved in research directly with our SHAPE network. So if some researchers come to us and say, I'm planning to do this study, I'd really like to talk to some people with epilepsy, we can share that opportunity and put them together, and then the people with epilepsy can comment and help the scientists really shape what they're going to do. I'm really running out of time, so I'm going to skip through this one, if you don't mind. Epilepsy, Marco. Yeah, all I wanted to say now is one of the issues and one of the challenges we have is making people aware of the impact of epilepsy on people's lives. And I want to draw your attention to this absolutely wonderful short film that was made by a young man with epilepsy in the States in 2018. He wrote and directed it. It's called Under the Lights, and it really is an insight into the impact of seizures on a young person's life. And if you wanted to Google it and have a look at it and share it, then it's there. And I will wrap up now because I'm sure there are lots of questions for Marco, but thank you very much.